Francesco Ceppi. He's from the Center of the University of Vaud, and he will present us in a hot topic, which is how to treat refractory and relapsing Burkitt's lymphoma and Burkitt's lymphoma. Dr. Ceppi.
Thanks, Shadi, for the kind introduction, and thank you for the organizer to invite me to talk about refractory and relapsed Burkitt lymphoma. So, as you know, non-Hodgkin lymphoma are the fourth most common malignancy in children, and as you know, non-Hodgkin lymphoma is a very heterogeneous group of disease, and as you can see here on the left, Burkitt lymphoma and leukemia are half of non-Hodgkin lymphoma in kids. Here, today we will focus the talk on relapse. So you can see Burkitt relapse, it's almost a quarter of non-Hodgkin lymphoma relapse in kids. Here just a very small cohort, but I think this slide shows very well that for relapsed non-Hodgkin lymphoma there is a huge difference between anaplastic large cell lymphoma relapse that can be rescued in maybe 7 patients over 10, and B non-Hodgkin lymphoma and almost a Burkitt, the survivor it's very poor. So relapse are very rare, and now with the introduction of rituximab, almost all the kids are treated with the first-line treatment. The problem of relapse that we have really not a lot of report on that, and also the majority of these reports are based on retrospective surveys, include different types of B non-Hodgkin lymphoma. You will see after there is a huge difference between diffuse large B-cell lymphoma relapses and Burkitt relapse. And another issue is that a lot of these retrospective studies show only patients who relapse, and they didn't include the patients who are refractory to the first treatment, that are around 30% of the patient. So the classical strategy following relapse of Burkitt leukemia or lymphoma, it's a reinduction chemotherapy followed by stem cell transplantation. And as I was telling you before, there is a huge difference between the B non-Hodgkin lymphoma relapses. You can see here from the French cohort, you can see that the patient who has a Burkitt relapse have clearly an inferior event-free survival around 30%. If we take some different experience between different study groups, on the left you can see the study from the French group, and you have an overall around 29%. Be careful, because here they include also diffuse large B-cell lymphoma, and in the middle the experience of the FAB-LMB96 study group, with also a survival around 20-25%, and on the right the BFM study group with a survival of 18%. So there is an improvement over time, yes. If you see on the left the curves of the French group, you can see that after 2000 there is clearly an increase in the survival. On the right, the BFM experience with improvement of survival after 2000, and also the small experience of the UK group. You can see also there an improvement after years 2000. Why? Probably the difference is the introduction of rituximab and also the introduction of stem cell transplantation. So just move to the risk factor for survival in relapse. So of course the initial risk group, and the first line, it's a risk factor. You can see in the 3 different study group. On the left, the BFM, clearly patients that were of the risk group R1 or R2, So patients of stage 1 or 2 have a better survival compared to the patient of R3 and R4. And for the French group, who is more familiar, here the group A and the group B with less than 2 times the LDH norms have a better survival when they relapse compared to patients of group B with high LDH and group C. And also the experience from the FAB LMB 96 study that was done between the US and Europe, and you can see that also there are patients with high LDHF and who relapse have a worse survival. The second risk factor is if the patient relapse before 6 months after the end of the treatment or had a refractory disease, have a worse survival. You can see always the experience from the FAB 96 study. You can see that this patient have clearly a very, very low survival. In the UK experience, patients who are refractory to reinduction are clearly very low survival, and in the French experience is the same. Patient who relapse after 6 months have a survival around 50%, clearly better compared to the patient who relapse in the 6 months. Rituximab therapy is also a risk factor. If you see the UK and the BFM experience, in the UK experience, patients who receive more than 1,500 milligrams square meter of rituximab have a better prognosis, and in the BFM experience, patients who receive rituximab during the relapse treatment have a better survival. And last, as Monica was telling you before, for the Hodgkin, also for the Hodgkin response to treatment, it's important. And you can see from the IBFM experience, patients who are in complete remission before going to stem cell transplantation is clearly a better survival. In the French experience, the same. Patients who are in complete remission after reinduction have clearly an excellent survival. And in the UK experience, exactly the same. Patients who are in complete remission have a better survival. And which kind of reinduction regimen we can offer to our patients? At the beginning of the 90s until 2000, people were used to give them the intense cycle of chemo of the first line treatment. So for the patient in the BFM, classical AA or CC group, for the LMB group, it's more RC with etoposide that is included in this cycle, and afterwards RI, so rituximab with combination of ifosfamide, carboplatin, and etoposide was a regimen was very used. And then we had other regimen, and the most recent it's RVICI, introduced by the German group of the BFM, and we have some slide afterwards. So all these reinduction regimen give a comparable remission rate around 70% if this patient have not received rituximab in the first line therapy. So now that rituximab is more used in first line, of course, things are changing a little bit. Here the experience of the COG group with RIs was a small study including diffuse large B-cell lymphoma and Burkitt, so all the mature B non-Hodgkin lymphoma. You can see for the patient who respond to this treatment, the survival was very good, and not the same for patients who didn't respond to this treatment. It's a quite toxic regimen with a lot of grade 3 and 4 side effects. And for the responder to RISE, as I told you before, 70% survive, 35% were Burkitt, but most of them were, of course, diffuse large B-cell lymphoma. And all the Burkitt who survived received stem cell transplantation. So just some words regarding the RVICI regimen. that was introduced by Willy Wasman in Germany, and afterwards other countries of the BFM use it in the last years. So the idea behind this regimen is to really address the aggressive biology of Burkitt lymphoma. So the idea is to give a synergic effect of rituximab combined with continuous chemotherapy regimen. And as usual, also in first line for Burkitt lymphoma, it's very important to have a time and dose condensed reinduction regimen with cycle that are one after the other without waiting too much the recovery of blood cells. And of course, they try to introduce some drugs that were not used in first line. So this is the regimen. As you can see, the patient received rituximab just before the cycle, a little bit like the LMB protocol, and then they receive continuous vincristine, continuum carboplatin, and continuous ifosfamide with 2 doses of either Radisson, and of course they receive Dex and Mesna with this regimen with a very high hydration, of course, and with intrathecal, 2 intrathecal during this regimen. And if patients were CNS positive, they receive more intensive IT treatment. This is a little bit the schema. So normally the patient receives the first cycle, then the physician has not to wait until the recovery. When the patient is doing well, they start very quickly the second cycle. They can change if they want. If the response is not so good, they can change from vincristine to Taxol and try to use these drugs. The problem of this regimen that because the cycle are one after the other, there is no time to harvest the stem cells. So most of these patients receive allogenic transplantation for this reason with low conditioning. These are the results that were just published some weeks ago in Blood. As you can see, in the cohort of relapsed patients, the patient who receive this regimen have survival around 67%. Almost all these patients were patients that were not exposed to rituximab in first line. This is important. And the only 2 patients who received rituximab in first line, one had a progressive resistant disease, and the other one was in remission and was cured. So it's difficult to say if rituximab in first line will change a little bit the result of this regimen. And all the patients were transplanted with an allogenic transplantation. Here also in a multivariant analysis of this study, you can see the reinduction regimen VICI has always a better prognosis, and you can see the other thing which is significant is the initial therapy branch, so every 3 years for a worst prognosis. And if we would move after the reinduction, this patient is recommended to give them bone marrow transplantation. So who does benefit from this stem cell transplantation? As you can see with this small study from the Japanese group, the patients who are not in remission, who are in progression, on the left you can see that bone marrow transplantation is really not beneficial for them. And also the experience from the UK and the experience of the CLG with the RIs patients who are not in complete remission after the reinduction, really allogenic transplantation or autologous transplantation is really not recommended. So chemo-resistant or refractory disease, no chance to benefit of stem cell transplantation. So which type of stem cell transplantation? The biggest studies is a study led by Tom Gross in the COG group, and in their study they show all the results of all non-Hodgkin lymphoma relapses but if we focus only on Burkitt, you can see that there is really no benefit of allogeneic transplantation compared to autologous transplantation in this kind of subtype of non-Hodgkin lymphoma, and also the French group showed the same thing, no advantages of allo compared to auto transplantation in this patient. As I told you before, in the BFM we still give a lot of allo just because this regimen doesn't allow autologous transplantation because we cannot harvest the cells. So the last part of my talk, I wanted just to show you some new drugs and new immunotherapy that are very fancy in these last 5-10 years. So first, ibrutinib. It's a Bruton tyrosine tyronase kinase inhibitors. So BTK are activated after B cell activation, and are very important for the regulation of the normal B cell development. So ibrutinib is an inhibitor of these tyrosine kinases. The preclinical data show clearly in vitro and also in vivo an effects of ibrutinib in Burkitt lymphoma, and as very frequent in pediatric non-Hodgkin lymphoma, we have to follow the experience of the heads ward. And here a phase 1 of a patient who relapsed after diffuse large B-cell lymphoma, not Burkitt lymphoma, who received ibrutinib combined to her eyes. And if you can see the recommended doses for phase 2, it's 840 milligrams daily. And the overall response rate was of 90%, with 11 patients achieved a complete remission and 7 patients achieved a partial remission. So actually there is a pediatric trial ongoing that has the aim to confirm that the pharmacokinetic of ibrutinib in pediatrics patient is very similar with what they found in the adults. And the idea is really to compare the survival of patients who receive ibrutinib plus RIs or RVICI. You can choose depending of your choice, compared to patients who receive only the reinduction regimen with rituximab without ibrutinib. This trial is ongoing. So if we move to immunotherapy, this is a little bit the Chinese menu of immunotherapy in non-Hodgkin lymphoma in children. Many ideas, many trials ongoing. I will focus a little bit on 2-3 things. Blinatumomab, of course, it's not very well known in non-Hodgkin lymphoma. The result in acute lymphoblastic leukemia are very encouraging, and now it's also used and randomized in the first line. So there are proof in preclinical data that blinatumomab has an effect in patients who has rituximab sensitive, but also rituximab resistant Burkitt lymphoma or leukemia. So these data are encouraging, and probably the best way will be to combine blina with a reinduction regimen to see the result. And of course, CAR T-cell are now on the pipeline. We will have some talks tomorrow, so I will not go too much in the details. But as you know, the results of CAR T-cell anti-CD19 receptor are very excellent in acute lymphoblastic leukemia. So with many publications of many groups, and now with the approval of many pharmaceutical products, and also in the adults world, a lot of excellent results in diffuse large B-cell lymphoma. On the right, you can see all the targets that we can target with CAR T-cell. So many of these targets are present in Burkitt lymphoma, of course. Just a slide regarding the experience of the Seattle group. They presented 2 years ago at the ASH meeting. So as I told you before, in non-Hodgkin lymphoma, in pediatric non-Hodgkin lymphoma, there are not not a lot of experience with CAR T-cell, and they show the data of only 8 patients. It includes diffuse large B-cell, primary mediastinal, and Burkitt lymphomas, and 1 patient with grade zone lymphoma. There is 5 patients over 8 response, 3 complete remission, and 2 partial remission. Not a lot of toxicity, that is quite well known in non-Hodgkin lymphoma, less than in leukemia patient. The problem that also for the patient who get a complete remission, the remission was not durable. This patient also, if there was a persistent of the CAR, they relapse. This is a little bit different compared to leukemia, and there were also some cases of CD19 negative relapse as we see in leukemia patient. And the other problem is we consider only Burkitt lymphoma. As you know, a relapse of Burkitt lymphoma or Burkitt lymphoma is refractory. It's very difficult to wait until the production of the CAR T-cell, 4 weeks of the production. This from one side, from the other side also probably the side effect, the cytokine storm will be really horrible. So at the moment, I don't think it's a strategy of reinduction, it's more a strategy of consolidation of probably a first or second cycle of chemotherapy, and then consolidate with CAR T-cell probably. And why not? Probably we have to wait a little bit more, but the generation of off-the-shelf CAR T-cell, as the experience of the GOSH in the UK, maybe can be a solution for this patient who need a treatment very quickly after the relapse or the refractory disease. The problem of universal CAR at the moment that they have not a very long persistence, so you need always to consolidate with allogenic or autologous transplantation. Just some word on IT rituximab. When I was in Toronto, we did a nice study on the relapse of B-cell malignancy in the CNS. We got 25 patients, 15 of them, so around 60% of the patients were CD20 positive and mature non-Hodgkin lymphoma. All of them were Burkitt and were CNS positive, and of all the patients that were included in this study, 72% were in complete CNS remission after IT rituximab combined most of the time with IT methotrexate. So the other patients that were included in this trial were almost PTLD patient. So it's also a solution for the CNS patients who are very, very difficult to treat and to put in remission in the CNS. So thank you very much.
And thank you very much, Professor Francesco. And now the floor is open for discussion. Any questions?
Hello, thanks a lot for this nice presentation. I'm just asking about the role of transplant and the outcome in, as you mentioned, the comparable outcome for autologous and allogenic. Is it generalized? Because sometimes you are facing a systemic disease or even not a chemosensitive, as you mentioned, so I can depend at that time point on the GVL more. So maybe allogenic could have a hand over autologous. So I think it needs somehow to be clarified to me, the results.
But the question, if you are not in remission, you can do whatever you want, you will not survive. You can do autologous or allogeneic transplantation, you will not survive. So the problem is really the response to the treatment. But if you have a good response, and you probably the best way will go to autologous transplantation because it's either easier and less toxic. The problem of the BFM regimen that this regimen doesn't allow you to harvest the stem cell of the patient because you will give the cycle one after the other. So you will not wait until the recovery of the cell. So it's impossible to harvest this patient. So almost all these patients get allogeneic transplantation, but not because allo and you have a better GVL like in leukemia, it's really because a question of harvest of the autologous stem cell.
Other questions?
Thanks a lot for your nice presentation. I'd like to ask about adding rituximab as first line for treatment of Burkitt or Burkitt-like lymphoma. As you mentioned, you now use it as first line. Is there any selection criteria to apply it, the staging or grouping, or the rifle all? As in our center, we have to use it for group C.
Very good question. I think I would rely on what Monica said before for the Hodgkin. If you have a very low risk disease, maybe adding rituximab, because we have not studied that I know now for low risk Burkitt lymphoma to show that rituximab is better. So maybe you can only add side effects, and then rituximab you have a complete ablation of B cells, so you have to give immunoglobulins. So I'm not sure that now for low-risk lymphoma you can really recommend. There is a study ongoing in the IVFM that is giving the rituximab in first line also for low-risk group. The idea is to reduce the chemotherapy burden in these patients, so there is a reduction in chemo, but we add a little bit rituximab. In my opinion, I don't know the opinion of Monica, in low-risk Burkitt at the moment there is really no indication to give rituximab. Maybe we just increase toxicity with rituximab if you add to the chemo.
Also, I need to ask about your experience in management of relapsing diffuse large or dry mediastinal.
Yeah, of course, as patients who get more easily in remission, of course. With RIs, honestly, 70% or more patients go in remission, and it's easier also to go to transplantation compared to a Burkitt. As you know, a Burkitt who don't respond, so you can do whatever you want, just they don't respond.
Thank you.
I have a question for you. So, for our Hodgkin lymphoma patients at St. Jude today, when they relapse and we take them for autologous stem cell transplant, we mobilize them before starting reinduction chemotherapy. So, is this something that you would not recommend in Burkitt lymphoma patients? So, if I have a Burkitt lymphoma patient that relapsed, and maybe do we just go ahead and collect, and we collect without giving chemotherapy. So we collect dry. We just give GCSF and collect.
I think it depends on the clinical condition of the patient. If it's a patient that we see the relapse, I don't know, in a CT scan follow up with just an increase of the size of abdominal mass, I think, of course, I will do the same. As we are trying to do also the same with leukemia to try to harvest the lymphocytes before going to reinduction to have very good lymphocytes for CAR T-cell therapy or other therapy, completely agree. And a lot of groups now mobilize without chemotherapy, just with GCSF.
Other questions?
So if I may comment, I totally agree with you that really the crux of the response in Hodgkin and Burkitt's lymphoma, when is there any residual disease or not, but at least the practice in the US, most of the centers would not offer an auto-transplant for Burkitt's lymphoma, not because of the mobilization issue, but at least the belief of most of the centers that allotransplant is indicated for relapsed Burkitt's lymphoma if they go into remission. Even rather than the issue of collecting, rather than the issue of mobilization and collection of PBC. So at least across Atlantic, most of the centers would offer only allotransplant for Burkitt's lymphoma if they go into complete response.
No, I know it depends also from the experience of the center, but now we really don't have data that can prove these things. So I agree with you, it's just a belief, but there are no proof of that. I know there are also people who transplant neuroblastoma relapse, but we don't have really strong data on that.
Sorry, can I comment what Sham said? I think it depends on the transplant setting and the expected transplant-related mortality. If you are worried about the transplant-related mortality from unrelated donor or having transplant, so it will overcome the benefit of allogenic transplant or the assumed graft versus malignancy effect. But in matched sibling donor, in our setting here, the transplant-related mortality grew 5%. So matched sibling donor toxicity and related mortality as equal as good transplant. So I could go for allogenic stem cell transplant and take a benefit of proposed graft versus malignancy effect. So it depends on the transplant setting and the expected complication from these all variables.
So it's a debate.
So I don't know in your analysis, the allogenic transplants, all of them from unrelated donor, or one antigen mismatch, or haplo-identical transplant, and even all of them that were subjected to allogenic stem cell transplant were group B or even group C, compared to those who were subjected to the autologous transplant, maybe all of them group B and they went in remission. And we all know if we have a systemic disease like Mahmoud said, maybe there is a benefit from graft versus lymphoma effect from the allograft. So it depends on many factors. It's not only you got the stem cell harvest or not. It depends also on the type of the donor, the outcome, the related mortality, the types of the disease, the phase, the nature of the relapse. It's a many factor.
Yes, but I think important thing also for the audience is always the experience of the center.
Yes.
Because if you think that you will save all the kids with relapse with allo transplant, I think it's not the recommendation. And if you can do autologous transplantation, I think it's clearly enough. We really don't have evidence that allo is better in this setting. There are supposition, of course, we think that maybe in Algeria, that it's clearly proven in leukemia, but not in this kind of tumor.
Thank you.
So in the publication that you had shown that came from Tom Rose, the only lymphoma that benefited from an allo was the lymphoblastic lymphomas.
It's clear because it's the same family as leukemia.
So thank you very much.